let's talk. We're going to talk about CO2, I guess, right? So CO2 from a this is going to be more clinically based, I guess. So from a physiologic standpoint, we use oxygen as kind of the product to produce ATP through all types of mechanisms and produce energy. CO2 is obviously our expelled kind of byproduct of that, right? So we create CO2 as a byproduct, and we exhale CO2. So it comes down to, again, you guys know I'm not artist based on the last lecture. We have our brain, right? You have your lungs, and we'll use this as the chest wall and muscles, right? So the muscles. So we'll create more CO2 when we exercise, or if we have sepsis, the body's under a lot of stress, right? And our body basically compensates for that by increasing our minute ventilation, breathing more. So we expel the CO2, right? So our minute ventilation is our tidal volume times our respiratory rate. So our respiratory rate goes up, maybe we take more deep breaths in. So what's the normal CO2 in a blood gas for the newbies? We'll question the newbies.
45 is the highest.
About 40, yeah, exactly. So pH normal, right, 7.4, but we say, anywhere from 7.35 to 7.45 is a normal pH, right? PCO2, which is our carbon dioxide, is anywhere from 35 to 45 is normal, right? So that's the framework. So CO2, when our muscles, our heart, our kidneys produce a byproduct, it's CO2, it goes into the blood, and it's about 35 to 45, right? That's where we like it, and our pH stays around this. So there's really three ways that our CO2 rises in our body. So you have the brain, so your brain makes you breathe, right? So if you're sedated, you have a huge intracranial hemorrhage or traumatic bleed, your brainstem may not want you to breathe, or you're brain dead, right? So your CO2 will rise because you're not breathing, right? That's number one. Number two is, let's say you have intrinsic lung disease where you can't transport that CO2 from the blood into the lungs so the lungs can exhale it out. Classic disease is emphysema or COPD, okay? And does anyone know the third? Why you wouldn't be able to get rid of your CO2?
Narcotics, medications.
So narcotics goes back to the brain, right? You make the brain sleepy, so it doesn't give the signal to the lungs to breathe the breath out. It's neuromuscular disease, so things like ALS, advanced ALS, not so much MS, they don't get that much retention, but more neuromuscular disease. Guillain-Barré, you've heard of, that's why these patients, flail on the floor. They can't actually do the mechanical work, so that's the muscle part of it. So you got your brain, you got your lungs themselves, and the muscles, right? So in your case, what was the reason? Sedated. So I don't know the details of the patient, if he had COPD or anything like that, but it's probably sedation.
I think he had OSA.
He was on CPAP at home.
Got it. OSA, COPD. We talked about narcotics, right? Does that make sense, though? So if we use the case as a framework, so the things you want to watch out when your surgical patients go for surgery that you really want to think about are OSA. These patients are obese, are at risk for hypercapnia, okay? Especially because they get intubated, they get propofol, they get narcotics, they get benzos. And so when these patients get extubated, oftentimes I see anesthesia do it, is these patients are still kind of sleepy and they extubate. A normal person, people like us, we'd be able to do that work, but patients with sleep apnea, they obstruct Patients with COPD, their airways are tight, so they retain CO2. So I often tell the anesthesiologist when I send a patient to you guys to operate on, or I'm doing a procedure on them, wake them up fully before you extubate, right? Because those are the patients you'll see a few times a month where they're in the PACU and they're like not waking up, you get a blood gas, you gotta throw them on BiPAP. Could have been avoided if they had some patience and woke the patient up. Okay, so always look at that pre-op pulmonary consult too, because we may say wake patient up fully before extubation. And narcotics is a huge thing. So this is a pet peeve of mine because I see it a few times a year too. Is the 82-year-old female with no COPD, no OSA comes in with hypercapnic respiratory failure because somebody put them on 1 milligram of dilaudid PRN, right? And if you have a novice nurse, she's just going to push that, and they're going to go into respiratory failure. So really, I know there's a big push for pain control, things like that, but I always push back against that. Start low, and then we can increase as you go, right? So for little old ladies, 0.25 of dilaudid. For somebody opiate naive, even sometimes I'll start 0.25, and then if they're still in pain, go to 0.5. Signs of early CO2 rising. What are the symptoms, signs? As soon as it goes to 7.46, are they going to be obtunded? What can clue you in?
Alternative status.
Okay. So most of these patients will start to just be a little off. They'll be oriented ×3, but they're a little sleepy. They're just not themselves. Some of them get a little twitchy, kind of in their fingers. And then they can progress to frank, altered mental status. They're usually not, there's rare cases that they can be a little agitated and like kind of pick at things, but they're not like your alcohol withdrawal patients. It's more of a sedative type situation. With the narcotics, how can you tell sometimes? What other signs can you tell? Oh, it's the narcotics, it's not really COPD that's maybe causing this.
Tiny pupils.
Exactly, pinpoint pupils, exactly. Pinpoint pupils, they might be a little hypotensive too. And one thing you can try is giving them, and how much would you give usually?
1 milligram.
Usually you'll start off with 0.2. Now if they're like frankly out, I'll give a milligram, or if they're coding, which I've been, I've seen where a patient gets too much dilaudid and they're in cardiac arrest, I'll give 2 milligrams of Narcan, or even 5 milligrams of Narcan at that point, just to reverse anything. But usually if they're a little hypotensive, if their pupils are tiny, start with 0.2. You can, within a couple minutes, give 0.4. Because if they're really in pain and you give that, they'll wake up really agitated if you give them a whole milligram. Okay, same thing for like heroin overdoses, things like that. Start low unless they're in life-threatening situation. Okay. The other type of medicines that can cause problems with hypercapnia?
Anxiolytics do that too?
Anxiolytics, benzodiazepines, so your Ativan, Verseds. Reversal agents for those?
Ramazepam?
Ramazepam, or also known as flumazenil. Also same type of dosing regimen, start low, 0.2, 0.4. With narcotic withdrawal and giving Narcan, you're pretty safe giving Narcan. Narcan's very safe. For the benzodiazepine, the flumazenil, you want to be careful that they're not on chronic benzos, because if they are, you might just want to wait it out with BiPAP or mechanical ventilation, because if you give a patient with chronic benzos flumazenil, there is a higher risk of seizures. Okay. But if it's like procedural sedation, they're out, they're benzo naive, by all means give flumazenil. Okay. Your questions? Any questions?
So going along, say with this patient that we're talking about,
Yeah.
You go there, patient's down, you think it's narcotic related, you give the Narcan, no response there, then what?
No response, Narcan. It depends on their mental status, and it depends on whether you really think this is opiates, benzos, or is this something else, right? So if they had neurosurgery, They got 0.5, they're coming back from a craniotomy, they got 0.5 of, dilaudid, the nurse comes in and now our patient is, out of it. What do you do in that case? What are the stepwise things you would do? Let's say the patient's completely obtunded. So in a case like that is, they've had neurosurgery, it could be the dilaudid, but they could have some intracranial bleeding. So in that case, I would probably intubate the patient. I wouldn't mess around with BiPAP. I would try Narcan before that. If they don't wake up, intubate CT head, right? Let's say this was a healthy guy, you got a milligram of dilaudid, he's out of it. I think you could be a little more liberal with that. Give him higher dose, give him escalating doses of Narcan, 0.2, 0.41, doesn't wake up. You could try BiPAP for a short time. Obviously get an ABG on all these patients, but if they're not waking up with BiPAP within a good 15, 20 minutes, especially if you don't think they're protecting your airway, go to intubation. You have to take over their respiration. So we'll talk about BiPAP and mechanical ventilation in a second. So it really comes down to what's going on, right? Like, is it narcotics? Is it COPD? Is it OSA? Is it anesthesia extubated too fast? Or is it an intracranial process? Are they bleeding in their brain? Did they have a stroke, right? So go down. It's simplistic to think about the brain. Is something causing the brain to malfunction? Is something causing the muscles to malfunction? Or is it intrinsic lung disease with COPD? Okay. So one way to, how do I slide this?
If you want another one, hit the plus sign.
So if you mind pulling up just a patient with their general chemistries. So in terms of patients, when you're looking at a patient's like electrolytes, or you're looking to a COPD patient and saying, are they severe COPD? Should I worry about them really decompensating? One thing you could look at is that they're just general chemistries. And if you look at the CO2, and a lot of nurses think that's carbon dioxide, but that's actually the bicarbonate. You guys know that, right? I've seen some physicians, believe it or not, they were interns, but think that this is the carbon dioxide. So this is actually bicarbonate, right? So the body compensates for increased CO2, right, by increasing the bicarbonate because they want to keep that pH in balance, right? So we talked about, a normal blood gas being 7.4 being the pH and 40 being the PCO2, right? So with severe COPD, when your FEV1 drops, below a liter or so, you can start to retain. So their PCO2 will rise, and let's say they have a PCO2 of 60, but their pH will only be around 3.36, 3.35, meaning they've compensated over time, right? So that's one way to tell. Sometimes I'll get a stat call, I have a patient with a PCO2 of 80, and I'm like, what's their pH? And if their pH is within normal range, that means they've had this for a long time, right? And they've compensated by increasing their bicarb. What's a normal bicarb, guys?
17 or 22, 26?
20, about 24. 24 is a normal bicarbonate, okay? So this patient has an elevated bicarbonate trying to compensate for your PCO2. You guys don't have to know the calculations, but for chronic patients, as your PCO2 goes up by 10, your bicarbonate will go up for each 10 increase by 4, okay? So if the same patient or a different patient has a pH of 7.24 with a PC of 60 and a bicarb of 24, very different patients, right? But they both have the same PCO2. Does that make sense? This one has accumulated it over time, likely COPD. This will be your intracranial hemorrhage or got too much narcotics type patient.
Something acute.
Something acute. And one way you can tell is, so you look at the bicarbonate on that, and you find an elevated bicarbonate that's 35, and you'll see this all the time in the hospital, 35 or 40 in a patient that looks fine. They probably are retaining for some reason. Either they have chronic COPD, chronic OSA with obesity, something called obesity hypoventilation syndrome. These are really big patients. Or they could be on chronic narcotics, chronic benzos, and have central apneas and retain. So that bicarbonate really helps you out, okay? So if that's elevated, think that maybe they're retaining CO2 at baseline, you can get an ABG. So what would you do in a patient who is, I mean, this is any patient with altered mental, we can talk about just altered mental status and the treatment of it at the end of it, but so patient, you get called, patient just had a 60-year-old female, COPD, had a cholecystectomy, is on the med-surg floors, you get a call that the patient is very lethargic. How would you proceed? How would you guys proceed then?
Labs. Labs.
You could get some labs, yeah.
Yeah. Electrolytes.
Okay. And like we were talking about, you could get an ABG, right? You could look at their medications, of course. Look, are they on anticoagulants? Did they, are they at risk of having stroke or intracranial hemorrhage? So you may think about CT head. First, always look at their medications too. So look at anything that Benadryl, narcotics, benzos, that's a big cause of just general altered mental status. You look at ABGs to look for that elevated CO2. You may get a CT head to make sure it's not an intracranial process causing their altered mental status, especially if they're on heparin or Lovenox or something like that, they're at risk. And then, like you said, you look at general labs to see if they have any electrolyte abnormalities like hyponatremia, hypercalcemia. So those are the kind of the differential of what you want to do. You get the ABG, her pH is 7.3 with a PCO2 of 60. So you think she's in hypercapnic respiratory failure, right? And so what would you do in that case? She's still, she can answer some questions, but she's like really out of it. BiPAP, right? And what would you start? Yeah, you usually look to the respiratory therapist as they start BiPAP.
Start with the on button.
Yeah, exactly. Start with plugging it in, and then you press on. And so you ask them to start BiPAP, but you guys really don't need to know this respiratory, and they'll probably call us. And the thing is, if you want to be safe, and the respiratory therapist is a novice, you can say start 15 over 8 or something like that, okay? And we're not going to get into the nuts and bolts of BiPAP, but the E is the EPAP. It's a constant pressure going in. And 15 is every time they inspire, that's what they're getting in above that continuous flow. Does that make sense?
So the pressure 8 is continuous.
Pressure 8 is kind of like CPAP, right?
Continuous, right?
Continuous, exactly.
And
Is
then
that the
15,
Sorry.
it jumps up to 15 when they take a breath.
Exactly.
Okay.
So the continuous CPAP, do you really need it? Not necessarily, but you put it on there just in case they have any sleep apnea or obstruction here. So that opens that up. And then this gives them that extra minute ventilation that we talked about by giving bigger tidal volume, so they're expelling. You could put a backup rate on this too, so if they're really not, they're breathing at like 8 or something like that, because this will only trigger, BiPAP will only trigger when they breathe in terms of this part of it. So you could put a backup rate of like 14 or 16, so the BiPAP will give them more breaths actually, will actually deliver a breath, okay? And if they're not waking up after, 20, 30 minutes, you got to proceed to intubation. We'll probably be involved with that case, in those cases. Obviously, think about giving Narcan early on, giving flumazenil for benzos that are not chronic, and then doing more of a thorough workup. Because we have had cases where we think it's hypercapnia, and it could be hypercapnia. This is the ABG, but no one takes the next step forward and gets a CT head to see why this happened. And the patient had a big stroke or an intracranial hemorrhage. So always think, why did this pH become like it did? Why did the CO2 rise? Was it the brain? Was it meds I gave? Was it intracranial hemorrhage, or is it something else that's causing this?
So I pulled up the timeline of that.
Yeah.
That event. Patient got to the PACU around 5:46. At 6 o'clock, the nurse indicated that the patient was not responsive to verbal stimuli. Then at 6:15, the patient got 0.8 of IV dilaudid. and that the patient desaturated soon after getting it. Then at 6:26, so 11 minutes later, patient got another 0.8 of dilaudid.
Yeah.
All right.
Responsive? What?
Right. Then 30.
He's not talking because it's his own name.
30,
I think they were trying to reach for the Narcan and
30 minutes later at 7 o'clock, there's a note that says patient arouses to voice. 7:42, 40 minutes later, patient gets up to the floor. Then around 8 o'clock, the floor nurse notes that I guess he's too sleepy, altered mental status, and unable to take meds. That was at 8 o'clock. And then soon after that, the patient arousable to vigorous stimulation. So this is 2 hours after getting 1.6 of dilaudid.
Right.
Then at 11:40, so 8, 9, 10, 11, 3 hours later, after getting to the floor, the patient was unresponsive, rapid response, and intubated.
Yeah.
So in this scenario, it sounds like we could have, if we have something like this again, we can employ some of these strategies, which is, plus or minus, you think it's Narcan because you look back and you see 1.6 of dilaudid within 10 minutes, given a couple hours later starts to get sleepy. You're saying Narcan, no response, then maybe try the BiPAP.
Yeah, I would give Narcan, if she's Narcan 0.2 or 0.4. If that doesn't work, just give a whole milligram. Doesn't wake up. BiPAP, on BiPAP, get a CT head. Okay, make sure there's not an intracranial process causing this. And then if not waking up on BiPAP, intubation.
So if at that point...
If you think like she's completely out of it, not protecting airway, you really shouldn't use BiPAP. We do. As intensivists, we do use BiPAP. Give it a short course of BiPAP, see if things reverse. If you're playing it by the textbook, people would probably say intubate, just if they're completely obtunded.
So with this patient, it sounds like they initially kind of got a little better and then slowly got progressively worse, even without extra narcotics. So is there kind of like a cascade effect where this patient, because of COPD, sleep apnea, he's already kind of reached his max to compensate, so then that CO2 builds and then he decompensates?
Yes, absolutely, because you'll reach a point where your brain then is so sedated it just won't breathe. As the CO2 rises, it'll synergize with the narcotic, and then you're just not breathing.
So my thought is, I don't know if I would have necessarily thought of CTing the head on a uncomplicated postoperative patient.
Right.
It wasn't like this. The patient wasn't going to be put there because there was a disaster in the ER. It was, let's do it just in case.
Right.
Extra set of eyes. But then you get called to the floor, and now this patient's unresponsive. Narcan's not working. I don't know if to be honest, I would have thought I got to check for a brain bleed. I would have been thinking more.
Hypercapnic, you're beyond the point that Narcan's going to work, and she had pinpoint pupils. Do you know? Or
it's not noted in the timeline.
So it's a lot of factors you do into that. I'm usually pretty quick because I've seen so many bad things happen. As an intensivist, that we will usually in an altered mental status that's not getting better, get a CT head.
So would you do it even on a patient that is not on anticoagulation? Because he was fresh.
Potentially.
We don't really start anticoagulation until close to day 1.
Yeah.
Normally.
It could still be sharp though.
Yeah. So 45 times out of 50, it's going to be negative, but sometimes you will pick something up.
So if you put somebody on BiPAP, how quickly should you start to see some effect?
15 to 30 minutes, you should see some effect. So they may not be completely bright, but they'll be starting to open their eyes a tiny bit, maybe mumble something. Give it more time then, especially in your COPD patients. Because I always get the call, he's not really waking up, we should intubate this patient, intubate this patient. This happened to me when we were in surge last week, and I said, just wait, for the COPD patients.
One thing we haven't mentioned too is EKGs. I feel like there's a lot of patients without any kind of history of AFib, post-operatively, all of a sudden, now they've gone to AFib for the first time.
Yeah.
They've known, and so
Yeah, exactly. It's a very tricky thing. And to your point, you know, does it synergize? And is there a point that Narcan won't work? Yes, there's a point where your CO2 gets so high that you're not reversing really the narcotic. It's just the CO2 has reached this point that the patient's just not going to wake up. You know, you need to ventilate them.
So in this situation, it would be acceptable to try the Narcan, try the BiPAP, wait 30 minutes, and at that kind of 30-minute mark, see, are they getting a little bit better or not?
Right.
And if they're getting a little bit better, give it a little more time.
Right.
If they're not getting better, probably consider getting the head CT
Correct.
at that point.
Correct. Right. And one thing that'll help you to protect patients at risk, those OSA, OHS patients, COPD patients, is something called end-tidal CO2,
Right.
also called capnography. So this measures grossly the carbon dioxide that you're exhaling, right? So it's not completely equal to your PCO2 in your blood, but it gives you a surrogate. So if you have a patient who you're worried about, you can ask respiratory, you can only do this on certain floors, you could definitely do it on PCU, to put them on capnography or end-tidal CO2. So if they're awake and their end-tidal CO2 is 40, whatever it is, you can take a trend and respiratory will call you and say, their end-tidal CO2 is up to about 50 or 60 now, it was 40 when they started, you may want to back off on the dilaudid, right? So it helps you kind of give a measurement, just like we use a pulse ox for hypoxemia. Hypoxemia is a very delayed sign of respiratory failure. End-tidal CO2 will tell you faster, okay? So you can just order that, ask respiratory, can you do an end-tidal CO2 monitoring on the patient, and then they'll keep track of that.
So it was ordered but not done. This patient had continuous pulse ox ordered.
Okay.
They're investigating why, they're looking into why that wasn't done, but would that have helped? at all?
The continuous pulse ox might have helped, but still the horse was out of the barn. By the time you get hypoxic from hypercapnia, it's helpful definitely. It'll probably save you from a cardiac arrest type situation, which is a good thing, right? So, but capnography and continuous pulse oximetry might have been, using both would be helpful. Okay.
Oh, that's good.
Anything else?
Any other questions, guys? No, I thought this was a good kind of foundation of like basic but very important first steps.
Yes.
And somebody who's post-operative, fresh post-op, because that's our kind of danger period.
Yep.
In that first 6-8 hours, few hours, that's why we check them. After, if they're kind of altered on things to do.
Right. Right. Yeah. Always look at the medications, because we cause more of the problems than some of the intrinsic problems the patients have. And really speak to the anesthesiologist if you know the patient has severe COPD, and tell them, really wake this patient up before you extubate them. It'll save you a lot of work on the other end.
Yeah. All right.
All right.
No, thank you very much.
You're welcome.
This is awesome.
Thank